Serena Fitzgerald, and I'm the chair of the Early Career Research Forum, and I'm delighted to welcome you to our kickoff webinar, which forms part of the Early Career Research Forum webinar series. These are set up as relatively small group events to allow us and our colleagues to share their research and expertise on research topics of interest to our networks. And of course, it provides a space for discussion in a supportive environment. Just to note, as we've said, the webinar today will be recorded and available on the Palliative Hub Professional. It's shared widely afterwards, and often large numbers get to view it over time, which is fantastic. It gains that traction online. So recording, as Mary said, will not take place for the discussions, just to allow it to be that safe space. So Kumar will be leading the Q&A, and that's where the recording will be turned off. If you'd like to enable captions, please do so, and this is available at the bottom of the screen on Zoom. And just in terms of some housekeeping rules, just to ensure that you remain muted during the presentation, rename yourself so that everyone can see your name, and you can do that on the right-hand side of the screen next to your name if you press the three dots. You can turn your camera off for the presentation, and if you need assistance, we can help you. And questions, just to keep them to the end, but do feel free to put them into the chat at any point. You can also raise a hand to speak during the discussion and Q&A at the end of the presentation. So my colleague Kumar, who's the Vice Chair of the ECRF, will facilitate the Q&A when the speaker has finished their presentation. So without further ado, I'd like to now welcome our speaker, who is Professor Audrey Roulston. She's a Professor of Social Work and Palliative Care at Queen's University Belfast. She has been a qualified social worker since 1996 and specialised in palliative care for the majority of her career in terms of practice, education and research. Audrey is currently the Programme Director for a new postgraduate diploma in palliative care for social workers and co-chair of the European Association of Palliative Care Task Force for Social Workers. So welcome, Audrey, and we're really looking forward to your presentation. Thank you.
Thank you very much, Serena. And thank you very much for the invitation to be here today. I really appreciate it. And given the interest that there is in relation to this topic, I think it's very timely. I know that there are some funding opportunities out there for underserved groups, so it's great to be part of this. So the topic for today is professional stakeholders' experiences and views of palliative and end-of-life care provision to people in prison in Europe. And I've called it Reflections because I want to look at different elements of the project and some of the challenges that there were around for that. So how and why did I become interested in this topic? So as you heard in my introduction, I'm a social worker. I have been since 1996. And I have worked in specialist palliative care and generalist palliative care. I've worked with older people. I've worked in physical health and disability. I've worked in child protection. So why did I become interested in this? And it was literally, I was on my way to work one day and I was listening to the radio and Paul McConville was being interviewed. And that was back in 2018. He was protesting at the time outside Maghaberry Prison in Northern Ireland. And it was due to a lot of questions he had following the death of his 22-year-old son, Dan. And I suppose it just struck a chord with me about why is that parent, you know, standing outside a prison to ask the questions? Why does he feel the need to protest? So that sparked my interest, and that was because I was a social worker and working in palliative care and offering bereavement support. And I couldn't understand why he needed to do this to get questions answered about his loved one. And it was interesting too, because I then went and looked on the Prisoner Ombudsman website and I found all of these reports that had been published by the Northern Ireland Prisoner Ombudsman. And those were following deaths in prison custody. And I started to read them. So obviously I read Dan McConville's first, and then I read the others. And it was just interesting and sad, I suppose, to see the trends that were occurring throughout this. And there were a lot of young people, young males who were in prison on remand, particularly who had taken their own life. And I started to then see that the challenges around whenever the Ombudsman was making their recommendations or their investigation about the need for support for staff working in the prisons, the need for support for families, and all of the challenges. that there were around that due to the legal process of an inquest. So that's where this all started from, really. And at that time, there was a faculty research initiative fund for staff in Queen's who wanted to undertake a piece of research at small scale beginnings of a project. And I was able to apply for that, and I received funding, and we set up a small team of colleagues to actually conduct a scoping review. And that's when I started to look at the international literature and to find out about the experience of the staff and the bereaved relatives of people who died in custody, prison custody. And then that led on to another opportunity a couple of years later, where I was able to apply for a mentor. So Professor Sheila Payne, who many of you probably know, she was appointed as my mentor, and she helped me to try and make sense of the data that I had extracted. And then I became involved with the Ombudsman, and we are continuing to do that work. She also encouraged me to make contact with Mary Turner, who is the current chair of the Prison and Palliative Care, or Palliative Care in Prisons AIIHPC Task Force. And I am the current co-chair of the AIIHPC Social Work Task Force. So it made sense to make all of those connections. And again, it was about being around like-minded people who were also interested in this topic. So whenever I met with Mary, she explained to me about the AIIHPC Task Force for Palliative Care in Prisons. So it was established in 2017. Mary was one of the initial co-chairs of that, and still is. And there's a link there if anybody's interested in finding out more information about it. And what Mary had explained to me, and I'm now a member of it myself, was about the aims. So they originally set up the task force to develop that network of professionals, a bit like the network that you have here now for early career researchers. So it was across Europe and internationally, and as wide as they could reach. And also the first piece of work that they had completed was a survey of prisons and prison systems, which has been published by Mary and colleagues and is available through the AIIHPC website. And then the second piece of work that they wanted to undertake was a survey to obtain insights into the experiences and views of key professional stakeholders. So they were looking at participating countries across Europe, and then Australia had become involved as well, as they had received funding. So these were our research questions. This is actually only some of them, and I wanted to share them with you today just to show the progression of how projects evolve over time and how they develop. So alongside the other people in the AIIHPC task force, these were the questions that were identified. So it was, how do the professional stakeholders experience or perceive the current palliative and end-of-life care being provided for people in prison? What are the barriers that professional stakeholders experience to being able to provide the adequate palliative and end-of-life care for people in prison? And what facilitators or enablers do professional stakeholders experience as well? And then what recommendations would they articulate to improve? And it took a long time to actually identify what the key research questions were. And then obviously you have to then think about, well, who's going to be involved? So as I said, with it being the European Association of Palliative Care and the involvement then of Australia, these were the participating countries then in the study that I'm going to talk about today. So Mary has already shared some of this at the AIIHPC conference in Rotterdam. So I'm taking a different slant on it so that you can learn more about the research. So you can see the leads for each of the countries. And we were very fortunate to have support to be able to do this piece of work. We were able to receive funding from the Health and Social Care Board, which is now the Strategic Planning and Performance Group for the Department of Health in Northern Ireland, who provided us with sufficient funding to employ Brenda. And you can see Brenda there on the left-hand side. And then Emma Carduff, who works for Marie Curie in Scotland, myself, and then Mary Turner. And this was our first opportunity at the AIIHPC World Congress in Rotterdam to actually meet face to face. So we did a lot of work online remotely because of COVID, And it was really good actually then to have the opportunity to meet face to face. And as I said, Mary, she disseminated some of the preliminary findings from the international study. And she and Brenda are in the process of actually writing up the findings from the international phase of the study. So one of the things that we found, we realized was really important in terms of accountability and progression, and in making sure that our funders and the wider research team met regularly and were accountable for what we were doing and how we were spending the money, was that we had to have a steering committee. And this is something I recommend people would do when they're doing any research project. It's one of those early important tasks that you need to do. And that was the same whenever I did the scoping review. It's about getting people around you who have a repertoire of different skills and knowledge that can then pull a piece of work together. And this was a new area for me. So for some reason, my slides keep moving on. So this was a new area for me in terms of the prisons. And whereas it was, Mary's very experienced in this particular area, and it was about how we had that skill mix. And Brenda's a PhD student, just ready to submit actually this summer. So she was really keen to develop her research skills and had some capacity to take on the part-time work. And that really actually helped to develop her ability to manage recruitment, to manage data collection, and all of the issues that went alongside that. So that actually helped her when she came to reach that point in her own PhD. So it was really important for Mary, Emma, Brenda, and myself to meet monthly, and really just to keep the momentum of the project going, to deal with any issues that were coming up in terms of the project and how it was running, and also just to make sure that we were accountable to one another and that we had very clear minutes of all of those meetings and very clear action plans. And then what we used to do as well was periodically we would have invited a wider steering group to join those meetings, because we felt it was really important that they understood some of the challenges that we were facing as researchers, also that they understood the progress that we were making with the project. And because obviously that involved the funders as well, and they were the key stakeholders involved in the delivery of palliative care to people in prison across Northern Ireland. And were able to put us in touch with other people then in other parts of the UK. So we were able to ask for their support. We were able to ask for help with the approval process, which I'll talk about in a minute. And then they were also able to give us the key people that we needed to approach to help with the recruitment, or to help with the ethical or the governance approvals as well. So we were then able to provide them with updates on how many people had consented to participate, how many had been recruited, and also then how many had actually been interviewed, and as well as that, the preliminary findings. So it was really important in terms of that accountability for us as researchers, and also to make sure that we were fulfilling what had been agreed in the memorandum of understanding with our funders as well. So I mentioned about the approvals. So this was a very, as I said, lengthy and complex process, because we needed the ethical approval from each of the participating organisations, and the governance approval from those organisations as well. So, for example, in Northern Ireland, we had the Research Ethics Committee within the school that I'm employed in at Queen's University, but we also had the Office for Research Ethics Committees in Northern Ireland, who then were able to cascade the information out to Scotland and England. Unfortunately, we didn't have somebody on the team from Wales, so we weren't able to collect data there. It was also about trying to negotiate the different pathways into organisations. So because you have health and social care, because you have healthcare in prisons, because you have healthcare trusts, and different people having responsibility for the provision of healthcare in the prisons, we had to navigate, I suppose, the different pathways in terms of receiving the approvals. And once we started to think about who we wanted to interview or who would be involved in the delivery of palliative care to people in prison, we realised then that we had to reach outside the prisons and outside the healthcare trusts or organisations, because, for example, we realised through discussions with our steering group members that staff from Marie Curie and from Northern Ireland Hospice were providing in-reach services to people in prison, or that people would have come out for compassionate temporary release, for example, to the Northern Ireland Hospice or the Marie Curie Nursing Service. We're providing services in the community to people on compassionate temporary release as well. So I've given you an example of all of the committees and approvals that we required for just for Northern Ireland. There was a similar amount then for Scotland and for England. And as soon as we talked about interviewing people who worked in a particular prison, we then had to think about who provided the in-reach services to that prison and who did they work for, who were their employers. And again, it was through some health trusts within Scotland and England. So as you can see, why I've said it's a lengthy and complex process, it very much was. And it was very frustrating at times, but we understood why it had to be done. We were told that there were other ways we could have got around that, but by using, for example, the likes of social media to alert people to a project taking place, but that would have also raised issues about when do you interview people if they're in employment, and they would still have to seek approval from their employer to participate in the interview. So we did it the way we did, and we're glad that we did, because it made sure everything was in place. Now, one of the challenges then of that was whenever you get one set of approval, and then you go to the next committee who then ask for revisions, you have to go back then to the first committee, and on it goes, you know. So whenever I had approval from within Queen's, I then went to the Office for Research Ethics Committee, and then we went to governance, and we went to the prison service. Maybe they asked for some changes, or the South Eastern Health and Social Care Trust, who oversee the delivery of health care in prisons in Northern Ireland. They asked for changes. Then we had to keep going back. So you can imagine it was a very lengthy process. And one of the changes we made was using Sonic software to be able to transcribe the audio files of the interviews. So that required an amendment to all of the documentation and required ethical approval to be repeated again. So it was quite difficult at times, because we got people then who were contacting us. So there was a bit of snowball recruitment went on as well. And then we had to get approvals within their organisation. And one of the other caveats that we had to help with this was we had written into the ethics approval application that we wanted to be able to recruit people who were members of the AIIHPC Palliative Care in Prisons Task Force. And they fell within that. So if people were already members, they could come forward without us having to go through their employer. So that was a help in terms of the recruitment as well. And once they started to tell other people about the project, there was some snowballing, or once we provided information in our newsletter that went out from the task force, again, there was some snowball recruitment went on too. So in terms of the design, it was cross-sectional qualitative interview study. So we really wanted participants to share the following. So it was, how would they define palliative and end-of-life care, what their most recent experience and role was in caring for somebody in prison with palliative care needs, or indeed it could have been, you know, a consultant or a member of staff in one of the hospices who was caring for a person from prison who had been moved there for the appropriate care. How was the care provided to people in prison who are currently sick? You know, so what did it look like? So we wanted to know about the prisoners with the long-term health issues, those who were diagnosed with life-limiting or life-threatening conditions, and actually how their care was being provided on an ongoing basis and not just for end-of-life care. And then we wanted to know who would be involved for people at the end-of-life care. And I suppose it was around the healthcare and how it was organised. Obviously, we're across jurisdictions between Northern Ireland, England and Scotland, and things are very different across each of those jurisdictions. So we wanted to know what that looked like so we could start to identify what worked well, and, you know, some new initiatives. And it was great to get all of those ideas and information about them. So to find out what worked well and what didn't work well, and then their recommendations, and then their thoughts on compassionate temporary release for people nearing the end of life. And we could see differences across the countries as Brenda was conducting the interviews. She conducted all of the interviews. The recruitment was happening across the study population at one time. So it wasn't that she was working in Northern Ireland first and England second, etc. So she was starting to pick up the trends and hear people talking about compassionate temporary release more in Northern Ireland than the other countries, for example. So we realised how important that was as a topic within the survey, or sorry, the interviews. So some of the challenges that we had, or I should say Brenda had, in terms of the individual interviews, were around the time and rearranging it. So obviously people are very busy, or they were in shift patterns, or there was a crisis that would have occurred. So often Brenda was set up to do the interview, but then the time had to be changed or rearranged. And I know that happens a lot, but it did mean that we actually lost some people because there was never another time that could be organised, or people were off for extended periods of leave and were no longer able to take part. So we had more people consent to participate than we actually got to interview. It's also thinking about the most appropriate platform. So we could have used MS Teams, telephone, or Zoom, and it was about what people felt most comfortable with at that particular time. And it was also then about how Brenda could audio record, and obviously people had to consent to that. There was a data protection issue that came up in relation to the ethics application, and they wanted to know exactly how long the recordings would be on the recorder for, how they would be transferred over to Sonics, and who would have access to all of those. And I suppose it's just about that data exchange between different software programs. So that was something that they really wanted us to explain in a lot of detail. They also wanted to know who had access to the raw data. So even though we were part of a research team, there was an issue for the ethics committees about who could read raw transcripts, which may contain some identifiers, or who would have access to those audio recordings. So it was only Brenda who was allowed to hear those audio recordings, and it was only myself and Brenda who were allowed access to the raw data, until everything had been anonymised. And then likewise, we wanted to minimise the burden to participants. So it was making sure that the interviews weren't too long. And that's an issue for all qualitative research studies, or all research studies, isn't it? Whenever you're thinking about the burden of the participants, and making sure that what you're asking is required and is data that you will be able to use in a meaningful way. And then what we found another challenge was about the cascading of invitations to staff. So whenever we received governance approval from an organisation, we were told a key contact person, who we then had to send the invitation to, who then had to cascade it to staff. And it often meant that there was a time delay because people are very busy, and it may not have been a priority for them, or it could have got lost in junk mail. And it meant then there were repeated opportunities or repeated invitations then to try and raise awareness, bottom up and top down, of the research study and the opportunity to participate in it. And then maybe people misinterpreting the inclusion criteria whenever they saw that invitation. So we had to do some information sessions then to try and help people become more aware of the study, and also to understand what we meant by our inclusion criteria. And then there were also concerns when we came to the ethics about what were we going to do if anybody reported any malpractice, or what were the boundaries of confidentiality around that. So again, that all had to be built into the documentation, and it was something that Brenda had to explain very, very clearly at the start of the interview. So whenever people from, a number of people from an organisation came forward, Brenda always offered them then the group interview if that was going to make it easier for them. But she had to have some ground rules, and I've just shared those ground rules there because I thought it was important for anybody who's thinking about doing a focus group study, or they're going to do qualitative data collection in this way, and to think about the importance of allowing people to speak openly, listening to the views and opinions of others without interruption, not criticising people, and avoiding that blame and speculation, or thinking about the language that's used and avoiding the assumptions. And also about trying to keep things confidential. So often within a research interview, you're saying that this will not be shared outside of this, but the researcher could not guarantee that colleagues working together would not share outside of this, that particular setting. So again, it's understanding the boundaries and the limitations of the confidentiality as well, and making sure that the participants are fully aware of that. And then it was important for us to think about the names, so it's very easy, as you know, when you're retelling a story, to drop in the name of the person a colleague or a place, and it was important then that those were kept out of the discussions, and if they were said during the discussion, that Brenda would have made sure they were anonymised then. And the same issue then about the malpractice, if anything had been disclosed as well. So this is looking at the international. So I will talk about the international, I will talk about the UK wide, and I will talk about the Northern Ireland at times, just to sort of show you the minutiae or the nuances across it. So we hope to recruit up to 240, so 20 in each of the participating countries. We actually recruited, it says 140 because there were 7 countries originally, so we had France as well, but they dropped out. We wanted internal and external staff. We were only looking at prisons where adults were living. And we wanted the healthcare and prison staff. We also wanted allied health, social care, prison governors and directors, as well as chaplains. So this is who we recruited then. So as you can see, we managed to recruit. So our aim had been the 140. We recruited 113. And you can see the breakdown there in terms of the male-female split, and also the internal and external to the prison. And you can see there the breakdown in terms of their profession. So we had the majority were nursing roles, and then you can see that we had others then within that sample. It was nice that we also were able to include the chaplains and the prisoner governors and directors, as well as the medical staff, because it's so important to have that sort of mix of different people with different roles and responsibilities for prison healthcare. So this is an example of or an illustration of the demographic data of the participants by country. So you can see this is from the full international study. You can see the breakdown then in terms of their age group, the male, female, and then whether they were internal or external. So for our UK-based arm of the study, we had 51 participants, 18 male and 33 female, which we felt was a very good, healthy sample, given that we were aiming for 60 across that. In terms of the data collection, you can see for the international study, we had 81 individual interviews and 8 group interviews, and they were conducted usually by telephone or video call. We didn't do any face-to-face interviews in Northern Ireland or the UK, but there were some other countries that did do that. So in the UK, you can see we had 41 individual and 4 group, and they were all conducted by Brenda. In Northern Ireland, Brenda said the interviews lasted from 18 to 52 minutes with a mean of 27. So you can see that some were very short and some were much longer. And again, that depended on the experiences that the person participating had to bring to it, and the level of detail that they were able to provide in response to some of the questions. So as I mentioned earlier, the audio recorded interviews were transcribed using Sonics. That was after Brenda had transcribed one of them, and it had taken her a very long time. And then because she was a PhD student, she was working alongside others who were aware of Sonic software, we felt it was worth the time and the effort to go back to ethics and get that amendment made. So there were some advantages and some challenges. The advantage is she could upload the interview and it could be transcribed within seconds. So you're talking less than a minute to transcribe a 1 hour long interview. The challenges were then obviously the voice recognition. So she was interviewing people from Scotland, England, Northern Ireland, and it was actually quite accurate in terms of the voice recognition. Now, there were a few times there were phrases that it picked up incorrectly, but as a qualitative researcher, you always need to check the accuracy of the transcripts anyway. So it was no different for her to do that than it was if she was checking it for a professional typist who had maybe transcribed it. So these were some of the themes that came out. And I've looked at this in terms of the Northern Ireland data. So I'll share some of that with you. So it was really important that we thought about, so if you think about the first question, it was about what were people's understanding of palliative and end-of-life care. So the big thing that came out for them was about the importance of individualized care and that people were looked at in a holistic way. And that was I suppose that's the goal, isn't it? If you look at any of the literature around palliative and end-of-life care, it talks a lot about holistic assessment, holistic care. One of the other key factors was around the relationship-based practice, which is something that we talk about a lot in social work. And there was a sense that that's what was happening in practice. There was also a sense that it was important to promote opportunities to discuss advanced care planning, and that was happening in practice. But it was also important that people could see beyond cancer for palliative care, and they felt that maybe there was a bit of a need for more education to raise awareness about the other types of illnesses that would fall within palliative and end-of-life care. And also then theme 2 was thinking about the provision of this to people in prison. So as you can see, there were various options. So there was the in-house, so what was provided by the prison service themselves, and they had full multidisciplinary team within the prisons. There was the in-reach then, so that would have been the specialist palliative care staff coming in to deal with specific issues for people in prison, to maybe give advice to the in-house team to decide whether or not, you know, somebody needed to go out to hospital then for care, or indeed if they needed to transfer out to a hospice. But for some people, they wanted to remain in the prison for their end-of-life care, and it was how that could be facilitated. What was identified was a lot of positives, and it was really important that we think that we highlight the positives. So there was a sense that people were very empathic towards the people in prison who required the support and the help for palliative and end-of-life care. There was a genuineness amongst the staff about trying to uphold their own professional values and standards. There was also access to specialist support and equipment as required within the prison setting, whether that was a bed, a chair, a hoist, etc. So it was an option to be able to bring that in. And then there was the high quality of care, and then there was the opportunity for compassionate temporary release as well. There were some concerns which buffered against the positives. So for example, the prison environment, you know, they were not built for probably the provision of a hospital bed or a hoist. Some of the rooms were quite small, or the cells are quite small, so it's difficult to have a number of members of staff working with somebody. So that's one of the concerns about the environment. Is there a lot of noise in the environment? You know, in terms of the access to medication, how is that stored? Is it secure? Are people vulnerable to having their medication removed from them? Is it seen as currency for other things, etc.? And then another concern that was highlighted by the participants was the need for secure transport to take people out to hospital appointments or specialist appointments, and that also required members of staff as well. And was the person in prison fit for that? Did they want to go? You know, was there enough staff and transport available to be able to facilitate frequent hospital appointments as well? One of the other areas we looked at was equivalence, and there was an issue around how people were perceived. You know, so for some of the people, both in the prison and in the hospices or the hospitals, they really had a sense that a lot of derogatory comments were being made about some of the prisoners. You know, so were they seen as a person or a prisoner? Were they seen as a person in prison, or as a person in need of specialist palliative care? And as a result of that, then there was a sense of stigma associated for that person in going for help or going for medical treatment or support. And maybe that was based on their previous experiences of trying to access help and support in the community. Also then thinking about fear. So for some people in prison, whenever they were attending hospital appointments or they were in receipt of care outside the prison setting itself, there was often a fear of some form of retaliation if they felt that their victims were still alive, or the victims' families were alive, and they were frightened for their own safety. Then was there a sense of discrimination versus safety? Did that person deserve, it's something that's in the literature quite a bit, did that person deserve a good death? And were the staff being protected in terms of providing the palliative and end-of-life care as well? And also was there respect and dignity being promoted as well? And there was a sense really that there was equivalence to the care that people in the community would have received for those who were in prison. But there was that real underlying, I suppose, stigma, or there were derogatory comments that were overheard being made, but not all of the time. I suppose it's keeping it within context. And then another theme that came out was the support for people in prison. So there were lots of professionals within the prison, lots of people there to offer support. So we looked at psychologists, social care peers, and family. Within Northern Ireland, there was a positive approach to compassionate temporary release. There are challenges around commission arrangements about bringing people in and out. There were perceived gaps about some of the support that was available for people in prison or their families. And then there were challenges around access for visitors, which is obviously a security issue for the family or the visitors and other members of staff and other prisoners. And then finally, the theme around seeing the person, not the crime. So there were some negative attitudes towards people in prison versus the provision of high quality care, but those were the minority. And what we saw was that high quality care was being provided by the staff. So these are just some quotes that I've put up there that show you some of the nuances in different countries. You know, so there's talking about having guards at the doors. There's talk there about you know, needing some personal care for people in prison. It's not just about providing the drugs, and it's, you know, not putting hands on or touching people for their own safety as well. And the importance of seeing the person, not a prisoner. I think about safeties, that was one there. You see there, PO1 Northern Ireland, it was talking about he thought he might have been at risk. His victims were at large and they were maybe connected, and his victims may have looked to extract revenge. So that was that person's fear when they were receiving care outside the prison setting. Looking at different procedures, you know, how could you have lock boxes? How could you store drugs safely? And also thinking then about the sense of community. So it is somebody's home to be in prison. That is often their home, but it's like, what are they going to receive the right care? Can the people in the prison actually provide that? But it's that sense of community that people have within the setting. So my final thoughts for people thinking about a topic or thinking about a research idea is find a topic you're passionate about. I told you at the start about Paul McConville, that just struck a chord with me, hearing him talk on the radio. Explore the published literature, find out the gaps, priorities, or what's going on in terms of development in policy, law, for example. So that's why we did the scope and review. Establish a strong research team, you know, so find people who have a shared interest, find people who have the research skills that you require, develop your proposal, and find, you know, apply for funding to be able to do the study well. And have very clear aims and research questions, and make sure they are achievable from the data that you're collecting, and that you're not sitting with a lot of data that you're not going to use, because I don't think that's fair on the participants. And also thinking about, do you have the appropriate networks and time to obtain the permissions, you know, so it's about being realistic about your timelines. So our next steps are really to write international findings up for submission to a palliative care journal. As I mentioned, Mary Turner and Brenda Brady are working on that as we speak. And then we would hope to disseminate the Northern Ireland UK-based research findings more locally. So I'm in the final stages of the report for Northern Ireland, and then just waiting for opportunities then to disseminate that through the funder and the key networks. And then that's me, if anybody has any questions.